Bismillahirrahmanirrahim. Now we are starting with the 12th session of the reproductive unit, and this is about preeclampsia. So in the preeclampsia, the definition is that new onset hypertension, systolic blood pressure more than 140 millimeters of mercury, and diastolic more than 90 millimeters of mercury at more than equal to 20 weeks of gestation. That is preeclampsia. So the definition looks kind of similar to the gestational hypertension. So you may say that preeclampsia is a type of gestational hypertension, but in this condition it is not just gestational hypertension. Along with that, it has proteinuria or signs of end organ damage. So in the gestational hypertension, we saw that there was no proteinuria or signs of end organ damage. Now in preeclampsia, we see the signs of, like, there will be proteinuria along with the signs of end organ damage, and the measurement of blood pressure, like more than 140 to 90, that must be taken at two separate occasions more than equal to 4 hours apart. Then the severe features, several features include more than 160. Oh no, severe features include more than 160 millimeters of mercury systolic blood pressure, or more than 110 millimeters of mercury diastolic blood pressure on two occasions which are more than equal to 4 hours apart, and that blood pressure measurement must be there for more than equal to 15 minutes. Then there will be thrombocytopenia, elevated creatinine, elevated transaminases, pulmonary edema, and new onset visual or cerebral symptoms. Platelet count of less than 100,000 per millimeter cube, creatinine more than equal to 1.1 milligram per deciliter, and headaches. Microangiopathic hemolytic anemia that leads to increased lactate dehydrogenase can also be seen. If these symptoms appear before 20 weeks of gestation, before 20 weeks, they suggest a molar pregnancy. Okay, so if these symptoms like proteinuria, on top of that they are end organ damage and a very severe hypertension, if these symptoms develop before the 20 week of gestation, they are indicative of the molar pregnancy. And if they're happening after after the 20 week of gestation, it is called as preeclampsia. Talking about the pathophysiology, so caused by the abnormal placental spiral arteries that leads to endothelial dysfunction and vasoconstriction resulting in the ischemia. So very first thing that is happening over here is that there will be abnormal placental spiral arteries that cause an endothelial dysfunction resulting in the vasoconstriction and ischemia, abnormal placental vasculature which leads to the placental hypoxia and ischemia, which in turn result in the release of anti-angiogenic factors into the maternal circulation. The release of these inflammatory factors from the hypoxic placenta causes endothelial injury. Damage to the endothelium increases its permeability, resulting in the proteinuria. Okay, and then in addition, dysregulation of the vascular tone results in the elevated blood pressure, which can cause end organ damage, such as to the brain, for example, the headaches and the visual changes, and the liver, for example, the abdominal pain. Incidence increases in the patient with a pre-existing hypertension, diabetes, chronic renal diseases, autoimmune disorders, for example, the antiphospholipid antibody syndromes. Complications: placental abruption, for example, we saw about that in the abruptio placenta, coagulopathy, renal failure, and uteroplacental insufficiency. It may lead to eclampsia with seizures and or HELP syndrome. We'll discuss that later on. And pulmonary edema can also be seen. So HELP syndrome is basically a triad of hepatic failure, elevated LFTs, I guess, and there is a lipoprotein excess or something. So we'll see that. Okay, let's see that right now. So where are we? HELP. So HELP syndrome is basically a rare pregnancy complication. Is a type of preeclampsia that causes elevated liver enzymes, okay, and low platelet count. Okay, so it stands for hemolysis, elevated liver, and low platelets. So there will be hemolysis, elevated liver enzymes, and low platelets. Moving forward, we have treatment for the preeclampsia. So the drugs which can be given are hydralazine IV, labetalol, or nifedipine, which is given per oral, I guess, nifedipine per oral. Okay, so IV, hydralazine, IV, labetalol, and nifedipine will be given through the oral route. Lower the blood pressure acutely to decrease the risk of stroke, to decrease the stroke risk. Then magnesium sulfate IV or IM, prevent or treat the eclampsia seizures, eclamptic seizures. Okay, what is magnesium toxicity? The clinical features include mild moderate and severe features. So mild features include nausea, vomiting, nausea, flushing, headache, and hyporeflexia. The moderate features will include areflexia, hypocalcemia, and somnolence, while the severe features will include the respiratory paralysis and cardiac arrest. The treatment is to stop the magnesium therapy and give the IV calcium gluconate bolus. What is eclampsia? Preeclampsia plus maternal seizures is called as eclampsia. So basically, gestational hypertension with proteinuria and end organ damage was called as preeclampsia, and preeclampsia plus seizures is called as eclampsia. Maternal death due to stroke, intracranial hemorrhage, or acute respiratory distress syndrome can be seen. These are all causes of maternal death in eclampsia. Treatment is IV magnesium sulfate and antihypertensive with immediate delivery. HELP syndrome. So HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. A manifestation of severe preeclampsia, blood smear shows histiocytes, can lead to the disseminated intravascular coagulation and hepatic subcapsular hematomas that can lead to rupture and severe hypotension. Treatment is done with the immediate delivery. The definitive treatment is delivery of the baby for the HELP syndrome. What is pathophysiology of the pulmonary edema in the eclampsia and preeclampsia? So firstly, there will be generalized arterial vasospasm and systemic hypertension that leads to increased afterload against which the heart is pumping. That causes increased pulmonary capillary pressure that will lead to the development of pulmonary edema. The pulmonary edema will lead to increased vascular permeability. Secondly, whenever there is decreased albumin, that also leads to pulmonary edema, and decreased renal failure can also lead to the pulmonary edema. So this is the pathophysiology of pulmonary edema in the preeclampsia and eclampsia. Okay, no. Pulmonary edema is also caused by the increased vascular permeability. Then we have maternal diabetes. So fetal effect of diabetes mellitus. The first one is embryopathy, congenital malformations, for example, heart and neural tube defects. Okay. Placental vasculopathy can lead to asphyxia, growth restriction, and polycythemia, and increased fetal insulin, that is, it can cause macrosomia, hypertrophic cardiomyopathy, and hypoglycemia after delivery. Macrosomia, let me see that. Macrosomia means that the term macrosomia is used for the newborn with an excessive birth weight, that is macrosomia. So the hypoglycemia after delivery is transient, because we know that whenever there is the mother is diabetic, so the pancreas or the fetus will be secreting excessive amount of insulin, and that excessive amount of insulin will cause hypoglycemia transiently after the birth of the fetus, after the birth of the child. Macrosomia can lead to shoulder dystocia. What is that? Shoulder dystocia. So the shoulder dystocia is defined as the vaginal cephalic delivery that requires additional obstetric maneuvers to deliver the fetus after the head has delivered and gentle traction has failed. Because if the child is like big enough, so we have to do some other measure like vacuum or maybe forceps, because the shoulders will get stuck into the vaginal canal, and to deliver that baby we have to do some accessory maneuvers. Hypoglycemia in the neonate of the diabetic mother typically resolve within 3 to 7 days of the birth with the hyperinsulinemia. As the hyperinsulinemia remits, persistent hypoglycemia should prompt investigation for the inborn metabolic abnormalities or the genetic defects, for example the insulin secretion, genetic defects affecting the insulin secretion, for example the persistent hyperinsulinemic hypoglycemia of infancy. Okay, that's hell of a name. Persistent hyperinsulinemic hypoglycemia of infancy. Then postpartum endometritis. What is that? Pathophysiology of the postpartum endometritis includes cervix serves as protective barrier to normally sterile upper genital tract, right? When the labor and delivery, especially the prolonged labor with rupture of membranes, uterine cavity becomes increasingly contaminated with the cervico-vaginal flora. So normally cervix does not allow the vaginal flora to enter the uterus, but whenever there is prolonged labor, so what is happening in the labor, that suppose this is the uterus which is contracting, so this portion cervix, so when the contraction is there, some of the flora of the vagina can enter the uterus, So after the C-section, so with the labor, especially the prolonged labor with the rupture of membranes, uterine cavity becomes increasingly contaminated with the cervicovaginal flora. After the C-section, the presence of foreign bodies, for example the suture material or the surgical instruments, and the post-surgical collection of the blood, for example the hematomas, they serve as the nidus for the microbial infections. Okay. Then suture repair of the uterine incision can produce necrosis of the myometrial tissue, which further contributes to the uterine inflammation and infection. Risk factor for the postpartum endometritis. There will be cesarean section. The risk factor: C-section, chorioamnionitis, group B streptococcal colonization, intrauterine instrumentation, preterm delivery, prolonged labor, prolonged rupture of the membranes, and retained product of conception. All of these things are a risk factor for the postpartum endometritis. The postpartum endometritis is polymicrobial, which means that typical organisms include Gardnerella vaginalis, Streptococcus and Bacteroides, Staph epidermidis, and Streptococcus agalactiae, that is group B strep. Present with a fever, lower abdominal pain, and malodorous lochia, that is vaginal discharge, following the delivery. Uterine fundal tenderness and leukocytosis can also be seen. The complications include peritonitis and sepsis via hematogenous seeding of the pathogen, hematogenous spread of the pathogens. Now we have postpartum ovarian vein thrombosis. Septic pelvic vein thrombosis that can occur after the complication of the vaginal delivery or C-section. So that is what is postpartum ovarian vein thrombosis. It is a septic vein thrombus, septic pelvic vein thrombosis that can occur as a complication of the vaginal delivery or the C-section. It is caused by the varicose triad, the triad of the it is a triad of thrombosis. So what happens in the varicose triad, there will be stasis, hypercoagulable state, and endothelial damage. In the case of stasis, pregnancy-related venous dilation of the compression of the pregnancy-related venous dilation and compression of the inferior vena cava and iliac veins by the gravid uterus. Hypercoagulable state, physiologic increase in the factor 7, 10, 7, 8, 10 von Willebrand factor and the fibrinogen to protect from the hemorrhage during the miscarriage at birth. Why is there hypercoagulable state? There is a physiologic increase of factor 7, 8, 10 and von Willebrand factor and fibrinogen to protect from hemorrhage during the miscarriage or birth, and endothelial damage due to the uterine infection or intrapartum vascular trauma. Okay. Stasis is because there is pregnancy related venous dilation and compression of the inferior vena cava, because when the mother is like supine or standing, so because of the growing uterus size there is compression of the inferior vena cava that leads to stasis. Hypercoagulable state is physiologic increase in the factor 7, 8, 10 and von Willebrand factor to protect from the hemorrhage during the miscarriage or birth. Okay, so we miscarriage or exceptional condition, even at birth there is bleeding. To protect from the excessive bleeding in that during the birthing process, the body physiologically develops a hypercoagulable state, and the endothelial damage can occur because of uterine infection or the intrapartum vascular trauma. It presents with a diagnosis of exclusion. So basically the postpartum ovarian vein thrombosis is a diagnosis of exclusion. We have to exclude all other common causes to reach at this diagnosis. Fever, unresponsive to antibiotics, localized abdominal pain 1 week after the delivery, diagnosis with a CT or MRI, most commonly the right sided. So most commonly it is right sided. Clot may extend to the inferior vena cava. Note, right uterine vein, the right uterine vein drains into the inferior vena cava, while the left will drain into the renal vein. But pulmonary emboli are rare. Morbidity and mortality is rare with them. Okay. Postpartum ovarian vein thrombosis. The risk factors include venous stasis, ovarian venous dilation, hypercoagulability, hormonally mediated increase in the clotting factors, and endothelial damage, intrapartum vascular injury. Clinical features include persistent fever after the delivery, localized abdominal flank pain, and no response to the antibiotics. Supine hypotension syndrome, aortocaval compression syndrome. So what is that? Pathophysiology caused by the gravid uterus compressing and obstructing the inferior vena cava. There will be decreased venous return, that is decreased preload, decreased cardiac output that leads to hypotension, and reflex tachycardia or palpitations can be felt by the mother. In severe cases may result in the loss of consciousness or fetal demise. So suppose that this is the mother who is lying straight and like she is okay. So this is the abdomen with the baby in that. So the inferior vena cava lies on the posterior wall, like it is like interior to the or maybe lateral to the abdominal aorta, but it is lying on the posterior wall of the abdomen. So this uterus will cause pressure on that. If the pressure is large enough, it can cause compression or even obstruction of the inferior vena cava. When there is obstruction, it can lead to the decreased venous return to the heart, that is decreased preload, and if there is decreased preload, so cardiac output will also be decreased. Resultantly, the hypotension will develop and reflex tachycardia will be seen. In severe cases, it may result in the loss of consciousness or even fetal demise. Presentation: combination of hypotension, pallor, sweating, nausea, and dizziness that occur when the pregnant woman lies supine or on her back. Symptoms resolve with sitting, standing, or when assuming a left lateral decubitus position. So patient must lie in the left lateral decubitus position, or maybe when she is lying down, she must lie in the left lateral decubitus position. Arises predominantly in the woman more than 20 weeks of gestation. So most of the problems which are related with the gestation are happening after the 20 week of gestation, that is like 5 months after the fertilization, right? Because 5 months, yeah, I guess it is like that. Then we have differential diagnosis of dysmenorrhea. Dysmenorrhea is a painful menstruation. Firstly, there is primary dysmenorrhea, crampy lower abdominal pain and back pain during the menses. It is the examination findings will be normal. There will be no exceptional finding on the examination. In endometriosis, pain peaks before the menses. There will be dyspareunia. Dyspareunia means painful sexual intercourse and infertility. Fibroids, heavy menses with clots, constipation, urinary frequency, pelvic pain and heaviness, enlarged uterus on examination will be seen. Adenomyosis, dysmenorrhea and pelvic pain. There will be menorrhagia and bulky globular and tender uterus. Pelvic congestion, dull and ill-defined pelvic ache that worsens with standing, and dyspareunia will also be seen. What is dysmenorrhea? So primary dysmenorrhea, on examination there will be normal findings, and pain pathophysiology, release of the prostaglandins from the endometrium causes the uterine contractions. Okay, then the secondary dysmenorrhea is caused by the endometriosis, adenomyosis, pelvic infection, or the uterine leiomyoma. Endometriosis, the uterosacral nodularity, adnexal tenderness. In adenomyosis, we have uterine tenderness and enlargement. So uterosacral nodularity or the adnexal tenderness will be there, and uterine tenderness and enlargement will be seen. Bleeding from ectopic endometrium will be seen in the case of secondary dysmenorrhea. Pelvic infection, cervical motion, tenderness, and purulent cervical discharge that leads to the bacterial infection and inflammatory response. And uterine leiomyoma, uterine contour irregularity and may be associated with the heavy bleeding. Then we have acute abdominal and the pelvic pain in the women. So acute abdominal or pelvic pain in the women can be caused by the Mittelschmerz disease, ectopic pregnancy, ovarian torsion. Then we have ruptured ovarian cyst and the pelvic inflammatory disease. So let's see them one by one. Mittelschmerz disease, it is a recurrent mild and unilateral mid-cycle pain prior to ovulation. Pain lasts for a few hours to a couple of days, and the ultrasound findings are not indicated. Let me see the Mittelschmerz. What was that? I don't remember it now. Mittelschmerz. So when it is searching for that, let's move on. Ectopic pregnancy, amenorrhea. So the clinical presentation of ectopic pregnancy are amenorrhea, because we know that beta Hg level. There will be amenorrhea because estrogen and progesterone level are high. Even in ectopic pregnancy, then abdominal or pelvic pain will be seen along with the vaginal bleeding. Positive HCG will be seen. No intrauterine pregnancy will be there. Then we have ovarian torsion, that is sudden onset, severe unilateral lower abdominal pain, nausea and vomiting. And then we have to wait for this. Mittelschmerz. Okay, got it. So transient mid-cyclic ovarian pain, mid-cycle hurts, common in the women who are not taking OCPs like oral contraceptive pills who are ovulating, due to the enlargement of developing follicle which irritates the peritoneum. Okay, so the developing follicle will grow large enough to irritate the peritoneum, and that will call Mittelschmerz disease or the mid-cycle pains or middle hurts. Follicular swelling and rupture fallopian tube contraction can mimic the appendicitis. Uworld point is that ovulation predictor kit measures the urinary luteinizing hormone and become positive 24 hours before ovulation. Let's move back to our 2010. Yep. So there we are talking about ectopic pregnancy, and then we have to do the so ectopic pregnancy we did that. Now talking about the ovarian torsion. So what happens is that sudden onset severe unilateral lower abdominal pain with nausea and vomiting. Unilateral tender head and axil mass on examination will be seen. The ultrasound findings will show enlarged ovary with a decreased blood flow. In the case of ectopic pregnancy, the ultrasound findings will show no intrauterine pregnancy. Then we have ruptured ovarian cyst, sudden onset, severe unilateral lower abdominal pain immediately following the strenuous or sexual activity, free fluid near the ovarian cyst, pelvic inflammatory disease, fever, chills, vaginal discharge, lower abdominal pain and cervical motion tenderness will be there with or without tubo-ovarian abscess. Then we have breast pathology. So firstly, let's look at the structure of the breast. From moving outward to inwards, first we will have nipple. Then after the nipple, there is lactiferous duct and the major duct. Both of them collectively. Okay, no. So this is lactiferous duct, and then here we have the major duct. Then these are the terminal ducts or the lobular unit, and then we have the stroma over here. So the intraductal papillomas, abscess, mastitis, and Paget's disease will affect the lactiferous duct and the major duct. The terminal duct will be affected in the fibrocystic change. Ductal carcinoma in situ, lobular carcinoma in situ, ductal carcinoma and lobular carcinoma. The stroma will be affected in the fibroadenoma and the phyllodes tumor. Here you can see the picture in which they have elaborated the same thing. This is the nipple on the outside. Then we have the sinus, or which was called, it was called lactiferous duct over there, and now they are calling it sinus. Then we have the duct, the major duct, then the lobules are over there, and the stroma is this fibrous structure that is present outside the lactiferous apparatus. Maybe introduction. The terminal duct lobar unit is functional unit of the breast. So the terminal duct lobular unit is the functional unit of the breast. Lobules make milk that drain via the ducts to the nipples. Lobules and ducts are lined by the two layers of epithelium, luminal cell layer and the myoepithelial cell layer. So what is the luminal cell layer? Inner cell layer lining the ducts and the lobules is responsible for the milk production and the lobules. So this is called the luminal cell layer, and the myoepithelial layer is the outer layer lining the ducts and lobules contractile function to propel the milk towards the nipple. So the lobules and ducts, so basically we are talking about the lobules and ducts. So let's go to the picture. So suppose these are the lobules and then we have the ducts. So they have two type of cells. First epithelium is the luminal cell layer and then myoepithelial cell layer. So the luminal cell layer will be something like this. Suppose this is the luminal cell layer over here and it is over here. So the function of luminal cell layer is to produce the milk, right? Inner cell layer lining the duct lobules is responsible for the milk production in the lobules. So milk production in the lobule is done by the luminal cell layer, and then we have the muscular cell layer that is surrounding that area, that is called the myoepithelial cell layer, and the myoepithelial cell layer will cause a contractile force to push the milk towards the nipples. Outer cell layer lining the duct and lobule contractile function propels the milk towards the nipples. Breast tissue is hormone sensitive. Okay, before puberty, males and female breast tissue primarily consists of large ducts under the nipple. Development after menarche is primarily driven by the estrogen and progesterone. Okay, so development after the menarche is primarily driven by the estrogen and progesterone. Lobules and small ducts form and are present in the highest density in the upper outer quadrant. Okay, so they are highest in quantity in the upper outer quadrant. I guess this is the site of most of the carcinoma development as well. So breast tenderness during the menstrual cycle is a common complaint, especially prior to menstruation. During pregnancy, breast lobule undergo hyperplasia. Hyperplasia is driven by the estrogen and progesterone produced by the corpus luteum early first trimester and fetus placenta later in pregnancy. So the corpus luteum is going to produce the estrogen and progesterone early in the pregnancy, and for the later in pregnancy the placenta will take over all the hormones, and then all of the hormones will be produced basically by the placenta. Then after the menopause, breast tissue undergoes atrophy. After the menopause, the breast tissue is going to undergo atrophy. What is lactorrhea? It refers to the milk production outside the lactation. It is not outside, it is present. The milk production is still within the mammary glands, but it is outside the lactation. It is not produced due to the lactation or something. It is not a symptom of breast cancer. It is caused by, the causes include nipple stimulation, for example, the common physiology cause, or prolactinoma of the anterior pituitary, which is the common pathology cause, and drugs can also cause lactorrhea. For example, when we are giving first generation antipsychotics, so they can lead to the development of lactorrhea both in males and females. First we will talk about the benign breast diseases. So the first benign breast disease include the fibrocystic changes, development of the fibrosis and cysts in the breast. So here you can see this is the fibrous tissue, and here we have the cyst. So the development of fibrocystic changes in fibrocystic, as the name indicates, development of fibrosis and cysts is called as the fibrocystic change. Thought to be hormone mediated, present as vague irregularity of the breast tissue. Lumpy bumpy breast will be seen, usually in the upper outer quadrant, often bilateral and multifocal. Okay, then the physiology, the pathophysiology, the fibrocystic changes, all of them are benign. Firstly, we will talk about simple cysts. So the simple cysts are fluid-filled duct dilation with a dark blue dome appearance. This is something that they often give you on the question stem. So fluid-filled duct dilation with a dark fluid blue dome appearance on the gross examination, it leads to the lumpy bumpy breast. That is simple cyst formation. Then fibrosis. When the cyst ruptures, there will be inflammation. Then that inflammation will lead to the fibrosis. Suppose that we have the cyst over here. So these are the cysts, like you can see over there. So these are the cysts, blue ones with a blue dome appearance. Whenever a cyst will rupture, that ruptured cyst will lead to the inflammation, and that inflammation will lead to stromal fibrosis. Then we have apocrine metaplasia. It is also called as benign epithelial alteration. Alteration to the lobular carcinoma cells, papillary metaplasia, and take on the appearance of apocrine gland cells. So apocrine metaplasia means that it is also benign epithelial alteration of the lobular epithelial cells into. Okay, so there will be alteration of the lobular epithelial cells, that is called as papillary metaplasia, and they will take the appearance of the apocrine glands or the sweat glands. Apocrine glands like sweat glands. Okay, so they will take the appearance of the apocrine glands. Okay, subtypes include sclerosing adenosis and epithelial hyperplasia. Remember, all the conditions which are studying till now, they are all benign. They cannot metastasize. They are not malignant conditions. So what is sclerosing adenosis? Increased number composed of compressed acini. So in the sclerosing adenosis, there will be an increased number of the compressed acini. Acini and stromal fibrosis associated with the calcification. Slight 1.5 to 2 times increased risk of cancer. So there is a risk of cancer with the sclerosing adenosis. It is not a cancerous condition, but it can increase the risk of cancer to 1.5 to 2 times. Okay, there will be acini and stromal fibrosis associated with the calcification. In the case of epithelial hyperplasia, increased luminal and myoepithelial cells, distended ducts or lobules filled with a cluster of cells will be seen, and there is an increased risk of carcinoma with the atypical cell. If the cells become atypical, so there is an increased risk of development of carcinoma with these epithelial hyperplasias. So here you can see, these are the pictures. Here we can see the cyst, and this is adenosis and fibrosis. So adenosis is the like basophilic or purplish. Adenosis is basically adeno word refers to the gland formation. So adenosis will mean that there is increased glandular tissue production, and fibrosis means that there is fibrosis like scar formation and stuff like that. Ducts with the apocrine metaplasia will also be seen. So these are the ducts having the apocrine metaplasia over there, and this is the picture of a cyst, I guess. And then here we have, like, what is it? I don't know. So I guess this is the blue dome appearance, the characteristic blue dome appearance which is seen on the light microscopy. I'm not sure about that, but I guess it is that. So inflammatory processes. So the first ones were the benign lesions, which included the fibrocystic changes. And yes, the fibrocystic change was the first benign lesion. Now we are going to talk about the inflammatory process, that is the second benign lesion. So that can include fat necrosis and lactational mastitis. So what is fat necrosis? Benign, usually painless lump due to the injury to the breast tissue. Up to 50% of the patients may not report the trauma. So because the trauma is like minor and they don't remember that. Calcified oil cyst on the mammography, necrotic fat and giant cells on the biopsy. So the calcified oil cyst on the mammography will be seen, and let's see what that looks like. Calcified oil cyst on a mammogram, it looks something like that. So this is the fibrofatty chain that looks like a calcified oil droplet on the mammogram. So here you can see a calcified oil cyst on the mammogram. Let's move back. Radiopedia. Okay, I guess it's a good site for radiologists. So coming back, the lactational mastitis occurs during the breastfeeding and increased risk of bacterial infection through the cracks in the nipple. Staph aureus is the most common pathogen. This is a highly tested upon concept, that Staph aureus is the most common cause of lactational mastitis. Treat with antibiotics, for example, okay, so you have to treat them with the antibiotics firstly, and secondly continue the breastfeeding, because females, they become cautious that there is mastitis, it would be painful, and on top of that there is pus coming out of the nipples. So is it safe for the fetus or not? So the women are advised to continue the lactation, because that is safe for the fetuses and also good for the mother to treat the mastitis. Because that will lead to the continued drainage to avoid the breast abscess formation. So if there is obstruction and the mother has stopped doing the breastfeeding, so that will lead to the abscess formation within the breast. Then we have periductal mastitis. Inflammation of the subareolar duct is called the periductal mastitis. What is periductal mastitis? The inflammation of the subareolar ducts, usually seen in the smokers. Relative vitamin A deficiency results in the squamous metaplasia of the lactiferous ducts, producing the duct blockage and inflammation. Clinically present as subareolar mass with the nipple retraction. Mammary duct ectasia. Inflammation with the dilation ectasia of the subareolar ducts, rare, classically arise in the multiparous postmenopausal women. Present as a periareolar mass with a green-brown nipple discharge. So if there is green-brown nipple discharge, that thing is called as mammary duct ectasia, because that is formed due to the inflammatory debris. Okay, so inflammation and dilation of the subareolar duct is called as mammary duct ectasia. Chronic inflammation with the plasma cell seen in the biopsy. So again, this is a picture of duct ectasia, like it is a swollen duct along with the duct inflammation. Okay. Then we have benign tumors. So now we are going to the tumors still benign. So these are the benign conditions. Firstly, we discussed this condition, that was fibrocystic change. Then we went to the inflammatory processes, including the fat necrosis and the lactational mastitis and periductal mastitis, mammary duct ectasia. Now we are talking about the benign tumors. The first one is fibroadenoma, the most common benign tumor of the breast. Most common in the women less than 35 years of age. Small, well-defined, mobile mass. Increased size and tenderness with increased estrogen, for example, the pregnancy prior to the menstruation. Usually regress after the menopause. Risk of cancer is usually not increased. So the risk of cancer is usually not increased in the fibroadenoma. Histopathology. Cellular or myxoid stroma that encircles and sometimes compress the epithelium lined glandular and cystic spaces. On ultrasound, hypoechoic mass versus the black cyst in the fibrocystic disease. So there will be a hypoechoic mass versus a black cyst in the fibrocystic disease. Hypoechoic mass. Okay, so in the fibrocystic disease we saw this thing, like this is a black cyst, like over here, and I guess in the case of fibroadenoma, that will be hypoechoic mass. As you can see, it is not completely black, it is like grayish or something. It is still darker than the surroundings, but it is not completely black. So that is a picture of hypoechoic mass on ultrasound. So this is a picture of the fibroadenoma, that there is slit-like cavities or slit-like ducts are present in the histopathology. Then what is intraductal papilloma? Proliferation of the normal epithelium within the lactiferous ducts, typically beneath the areola. Cells grow in the finger-like projections are called papilla. So in the intraductal papilloma, you will find papilla, like there are a lot of papillary structure like this. This is a papilla, and here you have another papilla like this one and this one. So these are the papillary structures which are found in the intraductal papilloma. So proliferation of the normal epithelium within the lactiferous ducts, typically beneath the areola. Cells grow in a finger-like projection of the papilla. Most common cause of nipple discharge, serous or bloody in the premenopausal women, not associated with the mass or lymphadenopathy. So the intraductal papilloma is not associated, there is no associated mass or lymphadenopathy in the case of intraductal papilloma. Slight 1.5 to 2 times increase in risk of cancer. Must be distinguished from the papillary carcinoma, which also present with the bloody nipple discharge. So this is papillary intraductal papilloma. It is not a papillary carcinoma. It must be distinguished from that. Papillary carcinoma, which can also present with the bloody nipple discharge. Papillary carcinoma is characterized by the fibrovascular projection lined by the epithelial cells without underlying myoepithelial cells. Risk of papillary carcinoma increases with age, thus it is more commonly seen in the postmenopausal woman. So the papillary carcinoma will be seen in the postmenopausal woman, while the intraductal papilloma will be seen in the premenopausal woman. That is one difference, and the other difference being the papillary carcinoma is characterized by the fibrovascular projections lined by the epithelial cells without underlying myoepithelial cells. So there will be no myoepithelial cells in the case of papillary carcinoma, but myoepithelial cells will be present in the case of intraductal papilloma. Okay, so there will be myopithelial. The presence of myopithelial cells indicate papilloma, while absence of the myopithelial cells indicate papillary carcinoma. What is phyllodes tumor? Phyllodes is the leaf-like projection. So the fibroadenoma-like tumor, it is a fibroadenoma-like tumor with overgrowth of the fibrous component. Okay, so it is a fibroadenoma-like tumor, and the fibrous component overgrows the maybe adenomatous component. So fibroadenoma is a fibroadenoma-like tumor with overgrowth of the fibrous component. Characteristic leaf-like projections will be seen on biopsy. Okay, large mass of the connective tissue and cyst with the leaf-like lobulations, most common in the 5th decade, that is like 50 or above, and that is the post-menopausal age. Some may become malignant. So the difference between the fibroadenoma and the phyllodes tumor is that the phyllodes tumor is occurring in the young females, like the premenopausal patients, while the phyllodes tumor is common among the postmenopausal women. So here you can see the structure, like you can draw it like a leaf or something. You can think of it as a leaf. So this is called the phyllodes tumor. Then the breast diseases. The benign breast diseases include fat necrosis, fibroadenoma, and the fibrocystic change. The fat necrosis is post-traumatic. Irregular mass and ecchymosis will also be present in the breast if it is post-traumatic. Pathology includes central necrotic liquefactive necrosis, central necrotic liquefactive fat, neutrophils and lipid-laden macrophages will also be present. Fibroadenoma, solitary round mass, firm with a clear borders, non-tender and mobile. Fibroadenoma will be firm with a clear borders and non-tender and also mobile. The fat necrosis can be painful because it is necrosis and inflammation is going on over there. So fibroadenoma tan white or on the gross pathology, fibroadenoma will be tan or white on cross section. Proliferation of the stromal and ductal element will be seen, and it is surrounded by the fibrous capsule. The fibroadenoma is surrounded by the fibrous capsule. Fibrocystic changes. So you saw it. Fibroadenoma, although it's a tumor, it is discussed as a benign breast lesion or benign breast disease. Now we are talking about the fibrocystic change, solitary mobile cyst or multiple diffuse nodulocystic masses, cyclic premenstrual tenderness. So there will be cyclic premenstrual tenderness in the case of fibrocystic change. Flattened epithelial or apocrine metaplasia surrounded by the brown or blue fluid, that is why it is called as blue dome cyst in the case of fibrocystic changes. And compressed fibrous adenoma, compressed fibrous trauma will also be seen. Gynecomastia. Breast enlargement in the males due to increased estrogen compared with the androgen activity. So normally the estrogen is present in the males, but there is a fine balance between the androgen and estrogen activity. If the estrogen overrides the androgen activity, this will lead to the gynecomastia in the males. Or the breast development in the male is called as gynecomastia. The physiologic causes: newborn male baby due to the placental transfer of the maternal estrogen, and it is transient. At puberty in the males, due to some androgen to estrogen conversion, that is transient. So gynecomastia normally physiologically occurs at puberty in some males, or in males, basically in all males at puberty we find some degree of gynecomastia because of conversion of androgen to estrogen, and that is a transient stage. Elderly males, less testosterone, more fatty tissue. So if you have seen like some elderly person, he may have development of the breast tissue because the testosterone level falls down, and there is more fatty tissue, and fat contains aromatase. So whatever testosterone is present, that can be converted into estrogen by the aromatase enzyme, and that is where they can develop gynecomastia. And in the newborn male baby, due to the placental transfer of the maternal maternal estrogen, that is also transient. So the newborn in puberty gynecomastia, which are physiologic, they are transient, while the one occurring at the elderly age, that is permanent. Pathology causes: cirrhosis, for example, decreased liver metabolism of estrogen. So one of the hallmark finding of the cirrhosis, the clinical picture that contains gynecomastia in the males. Along with that, there will be palmar erythema, and then there will be telangiectasias and flapping tremors and confusion and stuff like that, and there will be gynecomastia in the males. Hypogonadism, for example, the Klinefelter syndrome, there is decreased level of testosterone, so the estrogen overrides the level of testosterone whatever is present, and that causes gynecomastia. Then testicular tumors, they may also lead to gynecomastia because of some unknown reasons, I don't know, but testicular tumors, keep them in mind. Drugs include spironolactone. Spironolactone is a potassium sparing diuretic. It is an androgen receptor inhibitor. Hormones, okay, we are giving some hormones to them. Then cimetidine, finasteride and ketoconazole. Some hormones create funny knockers. So here you can see Common pathology causes of gynecomastia: increased estrogen production or increased peripheral conversion of stuff into the estrogen. So that is seen in the testicular, adrenal, or human chorionic gonadotropin secreting tumors, obesity, cirrhosis, thyrotoxicosis, and androgen use. Androgen deficiency: primary or secondary male hypogonadism, hyperprolactinemia, and renal failure. Medication effect: decreased androgen production, for example, the GnRH agonist and ketoconazole, decreased peripheral conversion to the dihydrotestosterone 5 alpha reductase inhibitors, and inhibition of the androgen receptors, spironolactone, and that is what bicalutamide. Then we have malignant breast cancers. They are very important. So commonly postmenopausal, usually arise from the terminal ductal lobular unit. So the malignant breast cancers, they originate from the terminal duct lobular unit most commonly. So if we could go back, so in this picture we saw that the benign lesions, including the intraductal papillomas or maybe the abscess of mastitis. Paget's disease is not like benign condition, but these things and other benign conditions, they are originating in this area, like the distal areas, the distal lactiferous duct and the major duct. But the main malignant lesions of the breast, like the DCIS, the ductal carcinoma in situ, or the lobular carcinoma in situ, ductal carcinoma and the lobular carcinoma, they are originating in the terminal duct lobular unit. So in the terminal duct lobular unit we find these tumors, the malignant ones. So commonly the malignant tumors are common postmenopausally. They are common in the postmenopausal period, usually arise from the terminal duct lobular unit, most often located in the upper outer quadrant of the breast, which contains the most of the bulk of the most concentrated area for the breast tissue is the upper and outer quadrant, if I'm not wrong. So when you're doing this one, so it was mentioned over there, like I guess somewhere here, the breast tissue hormone sensitive. So before puberty, yes, the development, the point 2, if you can see this one. So the development after the menarche is primarily driven by the estrogen and progesterone. Lobules and small ducts form and are present in the highest density in the upper and outer quadrant, and this is the same quadrant in which we are expecting the malignant tumors of the breast. So here you can see risk factors are increased estrogen exposure. For example, if you are doing the estrogen replacement therapy in a postmenopausal woman, or stuff like that. Increased total number of the menstrual cycles. How is that happening? The increased total number of menstrual cycles will increase the estrogen exposure to the patient, and that can happen in the case of early menarche or late menopause. Older age at first live birth. Okay. Obesity due to the estrogen exposure, as adipose tissue converts the androstenedione to the estrogen. BRCA1 and BRCA2 gene mutations. African American ethnicity, increased risk of the triple negative breast cancer. Triple negative breast cancer means that it is estrogen negative, progesterone negative, and ERBB negative. I guess it is a triple negative, but we will see what is meant by the triple negative breast cancer. So breast cancer risk factors, modifiable risk factors, and then we have the non-modifiable risk factors. So the modifiable risk factors include human hormone replacement therapy, nulliparity, increased age at the first birth, and alcohol consumption. So here you can see obesity is also a risk factor. Even low alcohol intake, less than 1 drink per day, increases the risk of breast cancer in the women. Moderate consumption, more than 2 drinks per day or less than 7 drinks per week, although moderate, okay, so decreases overall mortality and possible cardiovascular benefits. It has dose dependent causal effect on the breast cancer. So although moderate consumption, okay, so although moderate, it decreases overall mortality and possible cardiovascular benefits. It has a dose dependent effect on the breast cancer, also increases the head and neck cancer, also increases the risk of head and neck cancer. So I guess this is a confusing statement. If somebody understood that, please also explain this to me in the comment section or somewhere else. So but remember that increase in the dose dependent causal effect of the breast cancer. So the alcohol has a dose dependent causal effect on the breast cancer, and secondly, the alcohol consumption also increases the risk of the head and neck cancer. Then the non-modifiable risk factors include the genetic mutation of the breast cancer in first degree relative, white race, increasing age, and early menarche or the late menopause. So the breast cancer less than 50 years of age is associated with the genetic mutations, and ovarian cancer at any age, first degree relative, leads to genetic mutations testing. So if you have a first degree relative, who had this cancer, like ovarian or the breast cancer. So there must be a routine screening for the mutation, routine screening and the mutation testing to rule out the risk of development of breast cancer in the person. Exercise and breastfeeding is also protective. Menarche at age more than 13 will decrease the risk, and oral contraceptive pills decrease the ovarian carcinoma and not the breast carcinoma. So oral contraceptive pills will decrease the risk of ovarian carcinoma and not the breast carcinoma. Now we have the non-invasive ones, and then we'll move towards the invasive malignant carcinomas. So the non-invasive ones include the ductal carcinoma in situ. Whenever we listen to the term in situ, it means that the carcinoma is not invading, it is still in its place. Malignant proliferation of the cell in the ducts with no invasion of the basement membrane. So in situ means that it is in there, it is still in its place, and there is no invasion of the basement membrane. After about an hour of recording, now I come to know that my mic was not connected, and I hope that it does not have much of an impact. Okay, now let me connect it. So yeah, so malignant proliferation of the cell in the duct with no invasion of the basement membrane. So if there is no invasion of the basement membrane, we call all those carcinomas carcinoma in situ. Arises from the ductal atypia, often detected as calcification on mammography. Ductal carcinoma in situ does not usually produce a mass. Mammographic calcifications can also be associated with the benign conditions such as fibrocystic changes, especially the sclerosing adenosis. So mammographic calcifications, so in the case of ductal carcinoma in situ, you will find calcifications, right? DCIS does not usually produce a mass. So ductal carcinoma in situ is not going to produce a mass. The only finding that you can get about the DCIS is the calcifications. So mammographic calcifications can also be associated with the benign conditions such as fibrocystic changes, especially sclerosing adenosis and fat necrosis. Then biopsy of the calcification is often necessary to distinguish between the benign and the malignant conditions. So here you can see that the picture A, I don't know what is the picture A. So I guess this is ductal carcinoma in situ over here, I don't know. So these are lobe and ducts and the fatty tissue. So this is a normal duct, and here we have ductal carcinoma in situ with the abnormal cells proliferating inside the duct. Comedocarcinoma, the ductal dystrophic calcification in the center of duct. I guess it is a subtype of the ductal carcinoma in situ. So ductal dystrophic calcification in the center of the duct. So there is a dystrophic calcification. The dark blue one is the ductal is the dystrophic calcification. It is a subtype of ductal carcinoma in situ. Then we have Paget's disease. So Paget's disease, DCIS, that extends up the ducts to involve the skin of the nipple. That is called as the Paget's disease. If the ductal carcinoma in situ extend up the ducts and then starts involving the skin of the nipple, that is called as Paget's disease. There will be eczematous patches on the nipple. That is the buzzword they give you on the step exam question stem. So suppose that we have ductal carcinoma in situ growing over here. If it grows all the way from here outside over the skin of the nipple, so that is called as the Paget's disease. Okay, you're good enough though. So that is called as the Paget's disease. Crusty, scaly redness on the nipples and areola with oozing and bleeding. So oozing and bleeding can also be seen. Paget's disease is the intraepithelial adenocarcinoma of the cell. So this is the Paget's disease, as you can see in this picture. This is basically crusting and oozing going on over there. So here is the Paget's disease. I don't know what these cells are called, the highlighted ones, but this is the histological picture which you find on the slide of the Paget's disease. This one cell, there is another cell, and here are some cells like over here. So lobular carcinoma in situ. Malignant proliferation of the cell in the lobules with no invasion of the basement membrane. Again, because it's a carcinoma in situ, there will be no invasion of the basement membrane. So these are the malignant proliferation of the cells in the lobules, usually discovered incidentally on the biopsy. Lobular carcinoma in situ does not produce mass or calcification. For the ductal carcinoma in situ, we saw that the mass was not there, but calcifications could be seen. In the case of lobular carcinoma in situ, neither a mass nor calcifications can be seen. Characterized by the discohesive cells lacking the E-cadherin adhesion protein, often multifocal and bilateral. Treatment is done with the tamoxifen. So discohesive cells, because they don't have the E cadherin. That is the finding of the lobular carcinoma in situ. Treatment is done with a tamoxifen. Tamoxifen is a SERM, that is specific estrogen receptor modulator. It can decrease the estrogen expression or expression effect on the breast, but it will increase the estrogen effects or estrogen sensitivity within the endometrium. That is not the point concerned here, but that is the tie of the about the tamoxifen. So treatment is tamoxifen to reduce the risk of subsequent carcinoma and close follow-up, low risk progression to invasive carcinoma. So there is a low risk of progression to the invasive carcinoma in the case of lobular carcinoma in situ, so which means it is a good prognosis. Then after the break, we will go to the invasive carcinomas, which include the invasive ductal carcinoma and invasive lobular carcinoma and inflammatory breast cancer. Okay, so then we'll go to prognostic factors. So let's see you after the break.